Assalamualaikum warahmatullahi wabarakatuh. Good evening, ladies and gentlemen, all esteemed professors, urologists, other specialists, residents, general practitioners, and all medical students who are joining us right now. Allow me to introduce myself. My name is Hosea, and I will be your host for tonight's event. And welcome back to Jakarta Urology Medical Update 2020 in conjunction with annual scientific meeting of Continent Society of Indonesia. As we all know, this is a series of events organized by Yayasan Pengembangan Urologi Jakarta throughout September until October 4, discussing various topics in urology with both national and international speakers. But not only that, but also joined by international participants. First of all, on behalf of the committee, I would like to apologize for any inconvenience caused in joining our sessions this evening due to trouble in platform setting causing several emails sent for this event. And we would like to also to thank PT Advanced Medica Corpora Karl Stores in supporting this event. And again, we are glad to say this event will also support the COVID-19 relief effort in Indonesia by donating some of the registration fee. This is the second day or the second episode of our 6-day webinar, where tonight we will discuss all about endourology from our esteemed panelists. And now we will start tonight's event by kindly invite our moderator, Dr. Widi Atmoko, to lead and moderate these sessions and the discussion. And I would like to tell you something a bit about Dr. Widi Atmoko. Dr. Widi Atmoko was born in Jakarta, May 26, 1988, graduated as medical doctor from Universitas Indonesia in 2010, and as a urologist also from Universitas Indonesia in 2017, and currently active as medical staff, endourology and andrology or male reproductive division at Department of Urology, Cipto Mangunkusumo Hospital, Faculty of Medicine, Universitas Indonesia, and the head of Urology Division of Universitas Indonesia Academic Hospital. To Dr. Widi Atmoko, the time is yours.
So thank you, Dr. Hosia, for the introduction, and thank you for the opportunity. Assalamualaikum warahmatullahi wabarakatuh. Good evening, everyone. So welcome to our second episode of Jakarta Urology Medical Update 2020. Today, we already have 3 speakers here. For our international guest speaker, thank you very much, Prof. Cho. You have accepted our invitation, and I think we have 2 hours different time. So I think it's our pleasure to have you in this meeting. And also, good evening, Dr. Nur, Dr. Poncho, and also everyone. Thank you for joining this meeting. We thank you for the participants who already registered to this meeting. Today, we will hear 3 topics in this endourology webinar. Those are, the first session will be Dr. Poncho Biro, which topics is how can we perform supine PCNL, and the second topic is about the strategic after PCNL, exit strategies and follow-up management by Dr. Nur Rashid, and the last session from our guest speaker about the surgical options for kidney stones when we choose PCNL, RRS, and also the RIRS by Professor Sung Yo Cho. So for participants who have questions, can send the question through the chat box. And after the last topic, we will discuss the question from the audience. So I think we may proceed to the first session. We would kindly invite our first speaker, Poncho Birawo, to give his talk on how can we perform supine PCNL. So I will read about the short CV of him. Poncho Birawo, MD PhD, was graduated as urologist from Faculty of Medicine, University of Indonesia on 2005, and PhD from Hannover Medicine Hochschule, Germany on 2009, and currently active as medical staff endourology, stone surgery, and andrology, male reproductive and division, Department of Urology, Cipto Mangunkusumo Hospital, Faculty of Medicine, University of Indonesia, and also Secretary General of Indonesian Society of Andrological Society, and also the President of Indonesian Society of Endourology. So please welcome Dr. Poncho Biro. The time is yours.
Thank you, Dr. Widi, for kind introduction for me. Good evening, ladies and gentlemen, especially Professor Cho, who accepted our invitation to give a lecture tonight. Okay, I will start the presentation. Okay, tonight I will talk about how can we perform the supine PCNL. The presentation will be explained about the supine PCNL, PCNL as a urologist treatment, history, technique, advantage, and disadvantage of the supine PCNL. As we know that the presence of the stone in the kidney is about, in the urinary tract is about 2 until 3% of the world population. And the recurrent rates is about 50% cases within 10 years. And more men are more prone to urethritis than the woman, and more common found in the adult compared to in the children. So urethritis is the most common emergency case admitted to urologist emergency department. The choice of treatment, maybe later Professor Cho will discuss about it. We can have a conservative medicine, small stone. Larger stone is we can have a ESWL, whereas URS or PCNL. And open surgery is nowadays a little bit rarely done because most of the stone can be treated non-invasive or minimal invasive procedure. This is the guideline of the EAU 2019. And the principle that if it's small stone, we can use the ESWL or PCNL, and little bit larger we can do the ESWL or endourology, and the big stone usually we will choose the PCNL. This is the schematic procedure of the PCNL. Is we use the nephroscope entering the kidney, and then we fragmented the stone, and then we take out the stone. The position of PCNL is we can have several position. Most of them is we use the prone position because it's the first PCNL was done in the prone position. We can do the oblique modified of prone, is oblique prone or prone spigot. And about the supine, the first introduction of supine position is by Professor Valdivia, 1987, and then we do they make a modification with the Galdaco modified and use the position. And the lateral position can be also done, but it is rarely done. This is the first technique, PCNL 1976. The reason we use they use the PCNL, the prone position, is because concern about the other position, the colon injury during the puncture. Surgeon who perform the early PCNLs do not have a knowledge of perirenal anatomy, and because of the anatomy of the kidney is not well defined at that time, because the ultrasound or CT scan were not common. They use usually the IVU, intravenous ureterography. So since the CT scan is not common at that time, they prefer to do the prone to make sure that to prevent the colon injury during the puncture. And then in 1978, Valdivia Uria did the first supine PCNL with they use the preoperative evaluation, so we can make sure that the position of the colon is not retroperitoneal. At that time, demonstrate the good outcomes and lower complication. And supine have advantage is a better economics for the surgeon and less risk incident of retrorenal colon. Yeah, we can compare the supine 1.9% and versus prone position is 10%. 20% of the PCNL enter the global patient study of clinical risk of the endourology were performed in supine. So at that this time was 20% of the PCNL was done in the supine position. This is the Valdivia technique. They have marking in the inferior edge of the 12th rib, iliac crest, and the posterior axillary line. Place about 3 liter saline sac back beneath the patient legs to increase the degree of the position of the patient. This is the Galdaco modified Valdivia position. This is the most commonly used. Patient leg are placed in the modified lithotomy position. Both leg is stirrup. Yeah, this is to facilitate simultaneous percutaneous antegrade access. So we can do the cystoscopy or ureterorenoscopy simultaneous with the PCNL process. So this is the position of the patient. This is the contralateral side is in the modified lithotomy. This is the most commonly used. This is the Giusti position. Patient placed in the lateral edge at the table. So they use this foam to elevate the flank around 15 until 20%, and the ipsilateral arm is placed lying over the thorax. The leg of PCNL is left straight or without stirrup, and a single stirrup is placed to support the contralateral leg. This is the comparison between the Valdivia original Galdaco modified Valdivia and the Giusti. All the positions in the supine position, and the flank is elevated, but in the Giusti elevated generally only 15 until 20 degree, and the leg position is extended. This is pure lithotomy, pure supine. But Valdivia Galdaco modified, the leg is stirrup lithotomy. The arm position is not defined in the Valdivia and Galdaco, but in Giusti, the arm is placed lying over the thorax. This is the I make a meta-analysis. The supine position is have a lower stone rate in my meta-analysis, but the major complication is also lower. Yeah? And operative time, prone is there is a cystoscopy and takes time to modify the position and then do the puncture, fragmentation existing. But in supine, we can do the cystostomy pyelography, puncture and dilatation in the same time. I mean, there is no additional time to change the position of the patient. But in the meta-analysis, there is no difference operative time and length of stay in the hospital in the both groups between supine and prone. But there is advantage in the supine position. Yeah, it is clear that it is easier to do the simultaneous antegrade and retrograde access, and possible to combining laparoscopy and endourology. The other advantage is the movement of endoscope is less restricted. Puncture more lateral to abdominal wall, it's away from lumbar muscle. And nephrotomy tube is more tolerable when lying on the patient's back. And the advantage, another advantage is the lower intrarenal pressure because the because the position of the amplas is lower than the position of the kidney. So to make a wash out the stone is easier because using the gravity, the stone can come out by itself. So Another advantage of supine position is more comfortable for the operator. We can do the operation by sitting, less X-ray, less exposure to the operator because the operator's hand is not in the field of radiation. This is good for the obese patient, and the risk of puncturing the colon is lesser. But there is a disadvantage. The flank is not fully exposed. Sometimes difficult access to posterior and medial lying upper pole, and less ability to do the multiple access of the puncture. And the patient hips and operating table can give a restriction of instrument manipulation. Sometimes our instrument can, there is restriction because the table is give a restriction to movement of the nephroscope, but it can be overcome by moving the patient more laterally to the edge of the operating table. It's depend of the choice of the nephroscope also. Another disadvantage is absence of the abdominal compression. If the kidney is mobile, and then it is hard to dilate the tract. Another disadvantage is delay in filling of inferior calyx, especially in the anterior calyces, because the contrast will always going down to the back, to the posterior calyces. It's sometimes difficult to make a distension of the collecting system. In the very thin patient with renal ptosis, the kidney can be hypermobile in the supine position. This is learning curve from prone to flank position, defined by Zhang in 2011. It was said that the result will be different after 36 cases. We change from the prone to the flank position. This is I want to tell a story about our experience doing the supine position. Usually now I use the X-ray free and using the Alkan telescopic metal dilator to dilate the kidney. So the patient is, when I do the cystoscopy, the patient is, this is the GUST modified. The patient arm can be lying down in the special place for the arm. Okay? And then when I do the puncture of the kidney, the leg will be in the full supine position, but the left leg still in the in quote is in the lithotomy. So if I need more access to from the antegrade, from the retrograde, I can do the cystoscopy or URS. Can you show the video, the video of the committee? So I make modification so the ipsilateral of the leg can be moved using table. You can see in this video. Yeah, so the patient can move the leg easily to reduce the time using the special table. So to overcome the problem of the limitation of dilating the PL during the operation, I make I put guide wire and also ureteral catheter, and the ureteral catheter was pumped by water during the operation, so it makes sure that the kidney is still in the hydronephrosis. This artificial hydronephrosis that we can done during the PCNL, to make sure that the kidney is still always in a dilated condition. This is the result of the operation. maybe you can start the video. So this is when I do the operation after it is published in the Research and Report Urology. So I did the puncture using the ultrasound guided patient in the supine position. So I make dilatation using the Alkan telescopic metal dilator. So I have to make sure that the urine always come out from the metal dilator. It is possible since we can give the continuous water pump from urethral catheter that is inserted previously. Oh, this is the fragmentation of the stone. Okay, so take home message, supine PCNL can offer as an alternative technique of the procedure, as we know that there is no one position is superior to another series. There is always advantage and disadvantage for every position. So although the stone-free rate is relatively lower, the robot has a statistically lower complication. Supine PCNL also feasible in treating large kidney stone with appropriate instrument and proper exercise. Supine PCNL can be more comfortable for the operators since we can do the operation by sitting and less exposure of the X-ray. If you want to change from the prone to supine, it was known that after 36 cases, we can get the competence of surgical competence doing the supine position. I think that's all, Dr. Widi. Thank you for your attention.
Okay, so thank you, Dr. Ponchabiro, for talking about how can we perform supine PCNL, and very good explanation of the position process and also the plus minus of supine PCNL. So to remind again, for the participants who have questions, can send the question through the chat box, and after the last topic, we will discuss the question from the audience. So to begin the second topic, we would kindly invite our second speaker, Dr. Nur Rashid, MD PhD, to give his talk about strategic after PCNL, about the exit strategies, and also the follow-up management. I will read about the short CV of Dr. Nur Rashid. Dr. Nur Rashid graduated as urologist from Faculty of Medicine, University of Indonesia on 1999 and get the doctorate degree on 2009 and currently active as medical staff in Department of Urology, Cipto Mangunkusumo Hospital, Faculty of Medicine, Universitas Indonesia, and now he is the president of the Indonesian Urological Association. So please welcome Dr. Nur Rashid. The time is yours. Sorry, Dr. Nur, maybe you can unmute the speaker.
Yep. Okay. Thank you. Especially thank you for Dr. Widi and of course for Prof. Chu, our colleague from the South Korea, because this is a Friday night, almost midnight in your town. Thank you very much for for your time to speak with us for your competition in compete in this area. And of course, for Dr. Widi and the organizing committee, I want to say thank you to invite me to speak about the strategy after PCNL, how to exit and then follow up for the case. If we want to choose a strategy after PCNL or exit the strategy and follow up management, we have to know that this is the guideline for the kidney stone in Europe, America, and of course in Indonesia also. We have a guideline in 2019, almost the same. For the stone more than 20, there is the first choice is PNL. The second choice, Prof. Cho will be talk about this one, more about this one, where is the best for choices. All the guideline didn't mention about the hardness of the stone, but maybe in the next guideline, we have to put about the hardness of the stone, because just size and the location for the stone will make still stone free, a stone residual stone, or it will make a recurrent stone. From the guideline, maybe the difference between Indonesia in developed country, in this Indonesian guideline, we still put the open surgery for the big stone or a stone between 10 to 12 millimeters, especially in the remote area where they don't have ESWL, and of course they don't have PNL or flexible URS. The exit strategy, if there is a choices, we can choose, we will use a tube. There is a choices, we usually before we use a large bore. And then another choices is a small bore. And about in 1980, some guys trying to use tubeless. He tried to totally tubeless, but the result is not so good. And then it will be stopped. And all the PCNL doing with the tube. But in 1997, he started again, another urologist using tubeless with the double G stent or urethral catheter. But in some short case, they some limited case, they use a totally tubeless. Before we choose the exit strategy, what the purpose of the exit strategy is to reducing the morbidity of the patient, to prevent the patient discomfort, post-operative pain, of course, complication, especially urosepsis, urinoma, and the bleeding. And of course, we will just reduce the hospital length and will be compared to the cost and potential nosocomial infection. Appropriate exit strategy we have to do before and during PCNL. We can use, we have to use imaging with the contrast. Now we almost using non-contrast, and during surgery we do RPG. Before we do KUB and IVP or CT scan with the contrast. What the important to do this one, we have to know the infundibulum, how wide, how length, and how about the angle between the upper calyx, lower calyx, and medial calyx. And of course, we have to know the stone location, stone size, and the good thing with the CT scan, we know exactly how hard the stone with the Hounsfield unit. We know, of course, is there any hydronephrotic kidney? How about the pelvio-calyceal system? How many numbers of the calyx? Normally, we have 6 calyx, but sometimes in case we have 9, even 12. And with the radiology or during surgery, we have to know, of course, the ureter anatomy. And we have to mention about how big the tract we do in the surgery. Standard, mini, ultra mini, or a micro. It will be correlated with the exit strategy. From the prior to puncture, we have to choose from the radiologic examination from the upper, medial, or the lower. Depends on the size of the stone and the is there hydronephrotic there, and maybe because of the colon position. With the CT scan, we know exactly where is the best go to the puncture site. We can use fluoroscopy. Me, myself, doing triangular technique with the fluoroscopy. Sometimes I'm put ultrasound if the case so hard because there is a very limited space of the puncture area. So I'm combine a fluoroscopy with the ultrasound. Now, Dr. Poncho start doing only ultrasound for the puncture. How about the working dilatation? We can do telescopic mitral dilatation, semi-rigid, or a balloon. Along the dilatation, we have to know how deep our dilatation, how wide the infundibulum, and how about the angle from the infundibulum go to the pilum. With the fluoroscopy, we know exactly all the way we do. And of course, we have to choose the right lithotripter for our case. We can choose ultrasound, mechanic lithotripter. Usually, urologists will be happy with the combination. Laser will be used for this mini or a micro PCNL. Forceps, we can choose some kind of forceps. I'm happy with the flat jaw because I don't have to put so hard for the stone. At the end of the treatment, we have to see, is there any pelvio-calyceal laceration? Is there any bleeding? Is there any residual fragment? Or is there many urine extravasation? We can do straight with the endoscopy or with radiology. Especially if with the fluoroscopy, I always using visualization when I was withdrawing the nephroscope with the unplugged sheet, so I can see clearly if there is active bleeding in the parenchyma, or is there any complication for the organ outside of the kidney. For example, if we do upper pool puncture, we can puncture to the thorax, so we can see at that time before any complication after that. Now, in some country, I mean in developed country, people doing with the hemostatic agent. Me, myself, we never doing that because too expensive for our country. When I have a 3 complication of the bleeding after taking out the nephrostomy in the 24 hours, I do diathermy. When I withdrawing, if I see active bleeding, so I take a resectoscope, usually we use for a QR, and then put roller blade there, a roller electrode, and we do diathermy there. So the idea is we have to stop the bleeding at that time. If they stop, we can still put a nephrostomy or a tubeless PCNL. Tubeless, we can add the ureteric stent or a ureter catheter or the double J stent if there is a bleeding persist. So we have to put the nephrostomy, sometimes with the balloon inflated and retracted to push to stop the bleeding. There is some hemostatic agent. There is two types of there, passive or active. I saw in the Hanover, where is in the West Germany, now it's Germany, sorry, all the case, they use a flow shield. Even they do with the mini pearl. For our country, it's too expensive. And now there is a still further study to proving that the clinical benefit of this hemostatic agent. How about diathermal technique? Diathermal technique is already started in 2008 and 2004, of course, and this is the safe, simple procedure, and of course it is quite regular for us to do QRP, and then of course with the roller ball, and then we can do this, of course, in the bleeding after PCNL. We come back to the choices of the strategy. If we use a large bore, we use more than 80 French. For the small bore, we use below than 80. In my previous PCNL, I'm using 18 French. I have 3 cases with the active bleeding when I was taking out the nephrostomy. It happens because of the bleeding happens again when the pressure to the arterial bleeding and when we take it out the nephrostomy. So at that time, I moved to change to the small bore. I'm using pigtail with the 8-9 French at that time, and then moved to 6 French. But now, since 2010, almost or 99%, I'm using tubeless PCNL with the double G stent or with the urethral catheter. In some cases, in a very limited cases, and if this is normal, I'm doing totally tubeless. This is, for example, we can put the large bore nephrostomy here, like a catheter, 18 to 12. We can put the pigtail here, or we can put the nephrostomy, go to until to the nephroureteric stent. This is some choices. This is the pigtail, this is the Mallecot, and this is nephroureteric stent. For the nephrostomy, we can choose, we can take it out 24 until 48 hours after the treatment. Of course, we have to do like this, and if there is a significant bleeding, if there is any perforation or tear of the system, sometimes if we do multiple access, me myself just doing maximal for 2 access in one treatment. And if we do everything prepare before, during, and after the treatment, even I'm doing with the two track, I'm doing without the I'm still doing tubeless, but with the double J stent. This is usually even with the Stockhorn stone, but if there is an infection, we have to do with the nephrostomy to prevent the septic condition. How about the small bore? It's because of small bore will be reduced post-operative pain, shorter the urinary leak, reduce periods of hospital long stay, and prevent dysuria because to the stent placement. Now, at that time, some urologists, and now of course, some urologists move from the large bore to the small bore. This is the history of the tubeless. 1984, Wickham doing totally tubeless. At that time, they make a backfire because some serious complication. So at that time, post PCNL nephrostomy drainage, it has to be a practice, a standard practice for the worldwide. But in 1997, tubeless will started again with the double G stand, with the ureteric catheter, or just tubeless. So they found that this is the safe procedure because it is offered significant for the hospital stay, post-operative pain, uses of the analgesia, recovery time, and of course the cost. And several another advantage or disadvantages can be occurred. We will lose the track if we want to go again, and the discomfort because we have to take it out the double G stand if we put the double G stand out there. But there is some stand we can let the string there, and this is usually we use a double G stand, the single loop, double single loop with the string. But usually we cut the string. But if we want to use just a 24 hours, for example, we can let the string there and take it out, the string from the nephrostomy area 24 hours after the treatment. The using multi-coil stand, I found 3 cases come to me with the patient after URS and the after open surgery, but they cannot take it out the stand because of a delay, and then make the loop, spontaneous loop. When they take out from the cystoscope, the double G stand was broke. So they come to me to take it out the upper part of the double G stand. So for Indonesian, especially Asia, because we are not so high, usually the single loop with the 26 centimeters long, it's enough. Endopyotomy stand we usually use with the part of the upper part, larger diameter, if we do endopyotomy case after the PCNL with the stone, in the case with the UPJ stenosis. Tubeless with the standard, we found that now we found that the tubeless has a superiority because, like I said before, pain reduction, short loss, but sometimes we think contrary, that with the tubeless, the urine leakage will be reduced. At the first we do tubeless, we are afraid of the urine leakage, but that's proof from the meta-analysis. It shortened operating time, and of course, less operative pain, like some study, of course. The tubeless with double G stand or ureter catheter should be done if you try at the first time in uncomplicated case. With the single track, minimal blood loss, no evidence of collecting system surgery, we don't need the second loop of surgery in the short time. The double stand remove, usually we do between 4 weeks and before 3 months. In Indonesia, practically I'm due before 2 months because I found some case after 2 months, there are some encrustation in the double G stand, especially in the pilum. So it's not too easy to take it out the stand, especially in the local anesthesia. We can use we let the string and take it out with the string, but in the days, and we can use, of course, with the nephroureteric catheter stand, and of course, we have to take it out until 2 days, and totally tubeless. It is safe an effective procedure, even in the stock form, it will be reduced hospital stay, of course, analgesic requirement, and similar complication, especially if we do with the right strategy from the puncture, dilatation, how to fragmented the stone, and they decided at the end of the treatment before the exit. Follow-up, we have to do a follow-up ultrasound. Usually the case, sometimes patient after 1 day, resident doing KUB or just 1 week before, it can be false positive or false negative. Because of the dust or residual fragment, it will be go out after 2 weeks. So the best doing is after 4 weeks. Non-contrast CT scan, even the higher sensitivity, we can find the detect the small residual fragment, but it will be increase the exposure, of course the costly, but we even find there is some residual stone there, but without the clinically insignificant. So in our practice, if there is a radio opaque stone, we can do KUB. If there is non-opaque stone, we will do ultrasound to follow up the residual stone case. Except in the recurrent stone, a higher risk recurrent stone formation patient, we will do CT scan after 1 month. Of course, after the treatment, we have to do a stone analysis, because with the stone analysis, we will know exactly what the composition of the stone, and then we will make a right strategy to do a program to prevent recurrent rates. In Indonesia, now we have a laboratory to which can doing Fourier transform infrared spectrography, but we still don't have X-ray diffraction, whereas gold standard for check the stone composition. So the take-home message: exit strategy will have to be prepared before, during, and after PNL procedure, and should be choices at the end of the PNL for the patient safety. It's depend on the assessment of the case and the competence of the surgeons. Right exit strategy will be prevent the complication and morbidity of the patient. But now we know that the tubeless, with or without the double J stent or urethral catheter, will be reduce the pain, of course will be reduce the requirement of analgesia, shorter the length of stay, and the cost, of course, decreasing the urinary leakage, and of course will be prevent the uroseptic, and has equal stone-free rate and equal complication rate. So of course, Hamzamida for Prof. Q.
Yeah.
This is the picture where when I was visit the National University of NUH, National University Hospital in Korea. Thank you. There is a very nice visiting for 1 week. You let me ask to see all the procedure on your hospital. This is a very high standard, and we have very fruitful experience there. So we can practicing in our hospital, from the stone, from the Endourology, from the kidney transplantation, and of course our colleague from Dr. Ilfan, he's my head of department, who is a pediatric surgeon, a pediatric urologist, and of course my senior, Prof. Haidir, is oncologist, uro-oncologist. Very, very thank you, Kamsamida, Prof. Cho, what you do for us for a 1 week in show. Thank you.
Okay, so thank you, Dr. Nur, for giving the lecture about the strategic after PCNL. So I think it's controversial topic all the time in endourology, but you gave us good explanation with the evidence. So after this, we would kindly invite our international guest speaker, Prof. Sung Yong Cho, from Seoul National University Hospital to give his talk on surgical options for kidney stone when we choose. And again, thank you very much for accepting our invitation. And then before we begin the session, I will read short CV of him. So Prof. Sung Yo Cho graduated bachelor degree from Seoul National University College of Medicine in Korea on 2001 and graduated master degree from Seoul National University on 2010 and graduated Doctor of Philosophy from Seoul National University on 2012 and currently active as associate professor in Department of Urology in the Seoul National University, and now also as the head of the specialized endourology and stone clinic, or SEES center in SNUH. So please welcome Prof. Cho. The time is yours.
Thank you. Thank you for your kind introduction. Can you hear me?
Of course.
Yes,
Okay,
we can hear you, Prof. Cho.
This is my great honor, and especially this is very precious time for me because this is my first time to make a presentation for our Indonesian friends and colleagues, and that was a great time for all of us when you visit in my hospital, and we can discuss many things about stone surgery. So anyway, thank you for inviting me here, and today I'll talk about surgical options for kidney stone when you choose PCNL, RIRS, and ESERS. Yeah, please stay safe against COVID-19. Recently, more and more urologists are using flexible ureteroscopy after they overcome the learning curve in terms of scope damage with an acceptable cost. It induces us to use flexible ureteroscopy extensively for managing ureteral calculi, ureteral stricture, and urothelial carcinoma endoscopically. Now we call this endoluminal endourology. With the development of medical devices, we are facing some new technology such as flexible movement of ureteroscopy and cystoscopy and miniaturized nephroscope. Furthermore, the patient's position for stone surgery is changing from prone to supine, and now many urologists agree to the opinion that beginners have to know both of the prone and the supine positions together. Now we consider bidirectional approach for managing ureteral calculi in bilateral size and combined antegrade and retrograde approach for managing ipsilateral big multiple complicated renal stones as well. We call this CIRS, ESERS, namely endoscopic combined intrarenal surgery. When physicians meet the patients in the outpatient clinic, they are usually asked about the surgical procedure, efficacy and safety of the surgery, especially percentage of the stone-free rate status. Previous studies have shown the results about scoring systems of RIRS and PCNL, and I am normally using the S-risk scoring system that was developed in my center several years ago because it's very easy for me to describe the distribution of renal stones in seconds. Very short time, I can count the number of the locations of renal stones. But there is no validated scoring system for ESERs, and many urologists don't feel that the kind of scoring system is necessary because based on these scoring systems, we already may explain the same or higher stone-free rate for our patients with complicated renal stones. When you think of the topics to be cleared for determining surgical procedures for patients with stones, they are presence of bacteria, change of intrarenal pressure, size and distribution of renal and urethral stones, any renal anatomical abnormalities, irrigation and stone movement kind of retroposition, percutaneous bleeding risk and angioembolization risk, and the number of medical equipment and assistance. Basically, the choice of the right surgical procedure for our stone patients is not so simple. As you see here in this slide, there are some options to consider, including medical conservative therapy, shockwave lithotripsy, ureteroscopic and nephroscopic surgery. Additionally, we are using many equipment and devices, including disposable baskets, accessories, catheters, stents, and various kinds of lithotripters and irrigation devices. There are such a high number of cases to consider, and any change of them can affect surgical outcomes, and we can have trials and errors with newly developed or invented devices as well. We know that sometimes an unexpected worse surgical outcomes, surgical results can occur, even though we use the probably better devices than the old ones. This may be a matter of harmonization or combination across the devices and surgeons' familiarity with the devices as well. When it comes to ESERs, it is not only a matter of the devices about flexible ureteroscopy and nephroscope, but also the choice of the appropriate disposable devices for the newly developed scopes. Fortunately, when you learn how to perform combined approach, including ESERs, we are normally talking about the order of procedures, medical costs, operating room settings, and some indications of performing ESERs. When you choose the surgical procedures in the outpatient department, the first thing for me to choose the good cases for monotherapy of RIRS or PCNL. That is because it is important to prepare patient position and the surgical devices for our residents, nurses, and other assistants in the operating room. And of course, not because of my efforts. So if you worry about the possibility of position change from flank carrier to the lithotomy or the vice versa, we just need to request modify supine position to our assistant. If you want to perform prone position PCNL, the combined approach is also available, but the use of flexible ureteroscopy would not be so comfortable for us. So you have to check this first. So if the stone is as multiple small stones, I will definitely choose RIRS for them. And if the stones are standing in line or just a single stone in the renal pelvis, and if some other small stones are not located in the mid-porcalis, that it would be difficult to approach using flexible equipment through the percutaneous tract, then maybe I will choose PCNL monotherapy without hesitation. You can perform simultaneous approaches if you have proper number of surgeons, basically 2, and equipments. But when you fail retrograde approach to the stone, then you have to immediately apply the percutaneous approach without any position change, and vice versa as well. You can check these unexpected situation in this slide in the yellow boxes. So that means that we have to prepare unexpected situations, and we can guarantee both sides of both directions of antegrade and retrograde. Now let's move on to my recent case of stone surgery 1 month ago. I'll give you some time to check the CT scans, because every time I see some presentations that there's such a hurry for the presenters, so I couldn't check the CT scans carefully. So just you need to check the CT scans first. He is the 70-year-old man with right-sided big stones and left-sided small stones. The patient was pre-stented, and the transfusion was not available for this patient because of religious beliefs. So I performed left side RIRS first for him and removed all the small stones, and I moved to the right side in a single session. As you can see, the CT scan, there are these are some calyceal stones, and there are some parenchymal stones in the lower pole. Now I'll ask some questions to you, and please think of your own answers, and please type it in if it is available in the chat box, and I'll give you some time to think over. Just I don't want to get a right answer, but I just want to give some time to you to think over it. So how many can you see? How many stones can you see in the calyceal stones and parenchymal stones, actually respectively? You can see the CT scans. I have the right answer because I already performed the surgery. So just you can think, you can imagine, you can think your own answer. And if you finish your thoughts, then do you want to remove all the parenchymal stones as well? Those stones are not located inside the calyx. Basically, it's just inside the parenchyma, and maybe you can answer yes or no. Okay. When I did the surgery, I could find 2 to 3 calyceal stones, and more than more than 4 parenchymal stones in the lower pole. So what plan do you have now? Do you want to choose? Actually, if you don't have the right answer, then do you want to perform RIRS or PCNL? And if you choose RIRS or PCNL, do you want to plan to schedule staged operation or a single session operation? You can see the number of the Hounsfield unit. We can imagine the stone density. The maximum Hounsfield unit was 2,400, around, and the average was near 1,900s. Because of the transfusion was not available for this patient. I chose actually a staged up RIRS procedure for him. But while I tested a new holmium YAG laser from Quanta company in my hospital, the flexible URS was damaged because I think that is because of the acute infundibular pelvic angle, and additionally I could see some remnant stones as well. So if you this patient, you can see the infundibular pelvic angle was 78 degrees. And if you worry about the scope damage, and maybe you can choose a disposable URS for this kind of patient. And now, what is your next plan? If you choose PCNL, how many tracks will you make for this patient? Can you see this figure, KUB image? Then the stones are like this. Of course, you can have your own answer, and I'll make 2 maybe. For the second surgery. This case is scheduled several weeks later, and maybe I have to persuade him about the transfusion. But anyway, just I will tell you the results if I can have the opportunity. So there is still controversial about the percutaneous punctuation, percutaneous tracks in the supine position. So what do you think? How many tracks would be available for supine PCNL? You can see 1. All of these pictures are my cases, and this is 2 tracks. Yeah, 3 tracks, 4 tracks, and the last one is using flexible URS. While we do the supine position, apocalypse approach is absolutely available. And of course, the operating space is relatively narrow than prone PCNL, but we can make several percutaneous tracks very easily. Space is just space, and the next, the important thing is our experience. In terms of bleeding risk, less number and small size of percutaneous tracks must be better than multiple and conventional PCNL, although we can see some bleeding even with a miniaturized single percutaneous tract, as you see in this CT scan. Of course, small, just a single tract can be helpful to reduce the bleeding risk, right? Do you agree? But basically, we can see many bleeding cases, even we are using miniaturized nephroscope. So maybe we need to prepare various kinds of strategy for minimizing bleeding risks during PCNL. Preoperatively, ferrous component can be injected, and prior to surgery, 3 weeks prior to surgery, basically the hemoglobin level will be high at 3 weeks, a maximum level. Use of color Doppler ultrasonography to avoid large vessels. Of course, we cannot know the small diameter vessels, even we use color Doppler ultrasonography, but just we can see some Doppler movement of vessels. And nephrostomy insertion, tube insertion with blood clots in the ureter, especially, and use of hemosealants. Even it is still controversial because of the cost and the efficacy. Immediate postoperative CT angiography, a frequent check of hemoglobin level. Basically, I do this in every 3 hours, actually. Urine output check, because if there's no urine, then it must be the presence of blood clots in the ureter, and maybe the possibility of much bleeding. So we need to check the urine output. And continuous vital sign monitoring, maybe early transfusion prophylactic. There's controversial, of course. Early transfusion, reservation of angioembolization, ICU monitoring and care, an emergent nephrectomy. I did actually, it's on a single case when retroperitoneal compression is suspicious and maybe the patient's blood pressure cannot be maintained if there is any retroperitoneal compression. And another question to you is, do you think the ESERs can increase safety? Actually, there is little evidence about this. If you can see flexible you can use flexible equipment to avoid another unnecessary percutaneous tract. The bleeding risk can be minimized if you are familiar with the use of flexible equipment. If you are not familiar with it, however, yeah, the operative time can be ever and forever, right? So if you are confident at your flexible ureteroscopic surgical skill, then maybe you can use flexible nephroscope and maybe you can flexible URS just at the end of the percutaneous procedure. But another interesting finding, actually I recognized during my experiment, that is, I mean, we need to check there is no eternal truth in the world of stone surgery, because I recognize that there is never increase of intrapelvic, intrarenal pressure while I make two percutaneous tracts during PCNL procedures. So you can see the right side animation video, you can see the plateau in the intrapelvic pressure. This may mean that you should not remove the pre-established percutaneous nephrostomy tube when you perform PCNL, regardless of the position. The right bottom side picture means that would be just pre-established percutaneous nephrostomy tube, that is radiologist already made. Sometimes I do if the patients visit emergency department. I don't remove this percutaneous nephrostomy tube because to maintain the low intrarenal pressure. So can you remember the previous case I told you? Do you remember this case? Did you see the culture results actually? We can see the E. coli, that means the stone culture. E. coli lives in the stone, and the stone composition was just calcium oxalate monohydrate 80% and struvite 20%. It may mean that the increased recurrence rate and the risk of postoperative infection as well. So if there is a very high risk of infection, I may recommend you that you need to use multiple tracks you can consider the use of multiple tracks for patients. So my take-home message is like this. According to the evolution of medical devices, so PCNL and RIRS, a bidirectional and bilateral approach enables us to manage all the stones in different locations. Basically, the stone size is the most important factor to determine the type of surgery, but we have to consider stone density, stone location, distribution, and anatomy together, and all these factors are important. Sometimes we have to choose a plan with conflicting information. That means that I told you about the use of multiple tracks when it comes to the bleeding risk and the maintenance of low intrarenal pressure. So in terms of safety, basically we have to choose the best solution for our patients, but sometimes we have to consider relatively better options according to the patient's conditions and the stone status. So my key message, a single sentence, is preoperative consultation and individualized tailored treatment important, especially important in stone surgery. And thank you for your attention. And this is my great honor for having me here. Thank you so much.
Okay, so thank you very much, Prof. Cho, for giving us the explanation with good cases and how do you manage it. And I hope it also can broaden up our knowledge how to choose the surgery for the kidney stone. And also, we are so sorry that this Zoom webinar only have question and answer feature. So maybe during your lecture, maybe it's difficult to do the interactive discussion with the audience. So we are sorry. So I think we will go to the discussion session. We already have some question here. So the first question is from Dr. Pitramala. He had two questions. Maybe the first question for Dr. Birawa. Dr. Pitramala asks, do you have any suggestion for multiple puncture access? Any tricks and tips from your experience? I think if maybe besides Dr. Poncho, maybe Prof. Cho or Dr. Nur Rashid and can also give the answers also. So maybe the first from Dr. Poncho.
Yes, basically the supine position, the multiple puncture is quite good, and I normally I can use the pre-established percutaneous nephrostomy tube, but basically that is made in the prone position, and that is quite inconvenient for use for supine position. So basically, I make another new track. So that's why I show the picture in my slides with a percutaneous track and pre-established nephrostomy tube.
Okay, so how about Dr. Poncho? Maybe you did so many supine PCNL. Maybe do you have any tips and tricks for doing the multiple puncture?
One tips that I can give to Dr. Petra or the other audience, that if you want to do the multiple puncture, we have to do in the beginning before the dilatation. So make the puncture, put the guide wire first, and then we make the dilatation. Because in the supine position, after we make dilatation of the kidney, and then the kidney will be shrink. There is no hydronephros anymore. Then it's more difficult for us to put another track to make a new track if the kidney already shrinkage or not dilated anymore.
Okay, so how about Dr. Nur Rashid? Maybe you have some different approach or insights because you mostly do the prone position.
Yeah, because I'm mostly doing prone position, and now I'm usually now more than in an upper pool. Usually, if we will design first before the treatment. If we decided want to do 2 or 3 puncture, we will do at the first time before dilatation, like Dr. Poncho say, because in the prone position, it will be easier to do I mean, of course, especially in the supine, because after we do the dilatation, the kidney will be not dilated anymore. Even we will put the water from outside, usually, and of course, sometimes the kidney already move far away from the skin. So it is better to do multiple puncture first. Put the usually I put the zebra wire as long as I can put. If it can we put to the ureter, so let the all the 2 or 3 zebra wire go there, and then doing dilatation for the first puncture, and then if we need, dilate it to the second or the third puncture where already put the cobra wire, zebra wire there. Usually I will change with the urethral catheter first, put the urethral catheter, and then change with the super stiff guide wire, and then dilate it from that that area. So usually I just put the zebra wire for the second and the third puncture. But when we need to use this puncture, we will change with the super stiff guide wire in this area. Thank you, Ridi.
Okay, so how about you, Prof. Cho? Do you agree with Dr. Pocha and Dr. Nur? They usually made the multiple puncture first before the dilatation.
Yeah, sure. Yeah, I basically agree to the principle of Dr. Noor Rashid, because if I make the dilatation first, then the kidney cannot be nephrotic, and the space can be collapsed, and it is very difficult for us to make some percutaneous punctures. So I put in the guide wire first. If I want to make 2 or 3 percutaneous tracks, then I place the guide wires first. After I do the needle advancement, and then I use one by one if it is necessary.
Okay, thank you. So I think this topic is always controversial, but sometimes maybe some urologists do the multiple puncture after maybe from the first puncture they cannot stone free the stone. And I want to ask maybe from to the Dr. Poncho or Prof. Cho, how about the supine PCNL? Maybe for Prof. Cho, do you have any experience? Can you do the upper pole puncture directly in supine position? So
Yeah,
I
sure. I already show my upper pole puncture case in my slides, right? So
so without inferior pole puncture first. So you
yeah,
direct.
sure. Yeah, right. So basically, for upper pole diverticular stone, I normally make the direct puncture to the upper pole calyx. But basically, some guys are recommending the use of the supraclavicular supraclavicular approach, but it can make some lung injuries. So of course, although the angle is quite accurate, but I normally use the clavicular puncture, but it works. But I think the length of the parenchyma penetration is relatively longer than the puncture to the lower pole. Then I am using just ultra mini. My preference is using ultra mini perk for that upper pole calyx. But if the upper pole stone is very big, then of course I have to use the miniaturized PCNL. I mean the MIPM that is 16.5 French. I mean.
Okay. So how about Dr. Poncho? We know that maybe in Indonesia urologists, some of us use the renal replacement movement. So we usually puncture the inferior pole first, and then we put the wire and also the small metal, and then we push the kidney into the inferior, and then we puncture to the superior pole, because when we move the kidney to the inferior, the kidney, we can get the superior pole can more easily. So maybe Dr. Poncho, do you have any experience for the upper pole puncture in supine?
Yes, Dr. Widi, like you said that I prefer to do the puncture first from the lower pole, and then I lowering the kidney, and then I do the puncture for the upper pole. If we want to do it without X-ray, I have a little tips. We can use the guide wire from the ureter, the nitinol guide wire from the ureter. After we dilated the kidney, we can take the guide wire out of the. Hello, Dr. Widi?
Yeah.
Can you hear me?
Yeah, now I can hear you, because
Okay.
before the signal may be bad.
Sorry for the technical problem. So if we want to do it using the ultrasound guided without X-ray, we can put the nitinol wire into the ureter, and then we can take out the nitinol guide wire out of the kidney from the Amplatz seat, and then we can pull down the kidney and then make a new puncture for the upper pole.
Okay.
Good
So
technique.
yeah.
So, Prof. Cho, do you ever use this kind of technique, or maybe you always use the upper pole technique? I mean, the directly upper pole puncture all the time, if you want to do the upper
Sure.
pole.
Yeah, I know this technique through and through technique, and we can fix, especially we can use this technique for movable kidneys as well. So just it is quite it works very well for some cases. So sometimes I use if I just worry about the failure of percutaneous trick, because I am using ultrasonography and the kidney is movable, then just kidney can rotate. So maybe just we can use this kind of technique. And but basically I worry about the laceration, kidney laceration as well. So when we do this technique, so just we can fix it very forcefully, but I don't do it with much strength. So I just using the go and stop technique to staccato technique to make a puncture with my needle advancement.
Okay, I forgot to ask you, Prof. Cho, do you usually use the ultrasonography or fluoroscopy during
Sure.
the puncture? Both.
Normally, in almost all cases for needle advancement, and but for inserting guide wires into the ureter, the role of ultrasonography is limited. So I normally combine fluoroscopy together.
Okay. So how about Dr. Nur? Maybe for the upper pole puncture in prone position, do you have any tips and trick? Maybe for the location, or maybe do you have any precaution before doing the puncture? Sorry, Dr. Nur. Maybe you can unmute. Okay.
Of course, PCNL, we have to do a CT scan before, so we know exactly is there any dilatation. The good thing from the advantages of prone position, we do very easy to go to the upper pole. Even we can do from the lower ribs or between 11 and 12 ribs. It's depend on the location of the kidney. For the right kidney, we can do the below the 12 ribs. But for the left side, usually we have to do from between 11 to 12. But it is okay. If we have a CT scan, because in my cases, all 100% of our treatment with the PCNL is spinal anesthesia. We cannot ask anesthesia to expirate. That means to make the lung was compressed. But usually it is quite easy to do the upper pool, especially from the prone, because we have a wide area to do puncture, and we have a wide area to move our nephroscope to the upper side of the case. And usually we found the dilated system in the upper pool. So now more than 50% of my treatment I'm doing from the upper pool, because this is the one of the advantages of our prone position. Thank you.
Okay, thank you, Dr. Nur. So I think we can move to the another question.
Dr. Vidi, this is not a
Yeah.
debate between supine and prone positions, because I sometimes do prone positions as well.
Okay, okay.
There is big liver or retrocolon or big spleen, and then just there is no other option for supine PCNL at that time. So I do prone position PCNL or staged RIRS. So maybe it is important for us to share our tips and tricks for supine and prone, both of the procedures.
Okay. So you basically based on the condition of the patient, maybe you can
Yeah,
see from.
sure.
Okay, so I think we can go to the another questions. The same question from the Dr. Pitra Mala. So sorry, I can. So Dr. Pitra Mala asked Dr. Nur Rashid, but the other speaker can answer also. So if you have to place nephrostomy tube, for example, if there is a bleeding, so can you place the tube in and in the same time perform inspection of the tract during exiting procedure? So maybe Dr. Nur can give the answer first.
Of course, if before, usually now I'm regular, when I retract, withdraw the nephroscope, I will see is there any bleeding from the our tract? I mean from the parenchyma. Usually, because if we do fluoroscopic since we do a dilatation, we know exactly how deep we go and the angle, so it can prevent the trauma to the infundibulum, and of course decreasing the tears of the systems, pelviocalicial system, but sometimes still bleeding when the parenchyma side not at the tip of the calicial area. If it is happened, usually if very active bleeding, I will do like I said before. I will ask the nurse to bring me a QR system and then put the uh, roller to do hemostatic there, and usually succeed. But if there is still any bleeding, just put the 16, maybe 16 French of catheter, inflate the balloon about 3 millimeters until 5 millimeters, depends on how dilated the system. If we need retract the catheter for maybe depends on the bleeding time, and then if we see, usually it will be stopped spontaneously. I never doing open surgery for the bleeding because of the PCNL. Since I was start doing PCNL in 1999. So usually with the conservative, we can stop the bleeding. So I think that's why I say that if we want to decide it, what kind the exit strategy, we have to know from the beginning the system dilatation, angle of the infundibulum, diameter, the longest. Since we do puncture and dilatation, we have to know exactly the track we do, how deep, prevent the trauma of the especially infundibulum, arterial in infundibulum. If happens, I mean, if you make trauma in the artery of the infundibulum area, it will be horrible. Don't ever. I hope we don't ever find this case. Thank you, Idi.
Okay, so maybe Prof. Cho, can you give the answer? You know that there are some sheet with the clear vision. So maybe I don't know whether in Korea do you usually use that sheet that maybe when we do the nephroscope we can see clearly the surrounding of the sheet when we all do the whole the PCNL during the operation. So maybe do you have some?
I don't use transparent sheath.
Yep.
Uh,
Means transparent.
Yeah, basically, when we use it, just I think the placement of safety guide wire is important when you want to see the track when you withdraw the percutaneous sheath, and while we do the irrigation forcefully, then if you see the bleeder, then that must be arterial bleeding, and venous bleeding would not so definite while we do the irrigation, so we can differentiate arterial bleeding from venous bleeding, it is very important. And for venous bleeding, hemosilat can be effective, but basically for arterial bleeding, hemosilat would not work. So, but basically, while we make a hole, percutaneous hole, that this space can make more bleeding. So sometimes we need to collapse this parenchymal laceration space. So it can be helpful for bleeding control. So at that time, I don't place percutaneous nephrostomy tube. Instead, I just place a guide wire and I just put it in the skin with transparent waterproof tape. And if we need to do something later for the future, then I can use this guide wire and just 2 or several days later. And basically, when it bleeds, when it actively bleeds during operation, just I really want to check intraoperative angiography, right? But there's no way to do the intraoperative angiography. So I just request to my residents, okay, just prepare and reserve make an appointment of just immediate postoperative angiography first. And if there is no bleedings in the angiography, then I just follow frequently the laboratory results, including hemoglobin. So maybe just I think the preparation for catastrophic situation is important when much bleeding is when we're suspicious.
Okay, so but for the
Dr.
bleeding,
Widi,
yeah, Dr.
about
Nur?
the transparent sheet,
Yes.
I think it's not so important like promoting, because
Okay.
like Prof. you say, that the bleeding from the arterial will be happens after the nephrostomy tube will be taken out. So even transparent, there is no bleeding at that time. The bleeding will be happen after the sheet will be taken out. So I do the same idea with Prof. Joe. At the first time, I do large bore. And then when I take it out at the 24 hours, because the depressing of the artery bleeding was stopped at that time. But when we take it out, the large bore, the bleeding, it's happened. It's happened 3 times since 2000 until 2005. At that time, then I moved to the small bore. After that, I moved to the pigtail. And now almost I never using nephrostomy tube again, except one condition. If there is a bleeding active, even we do already try to stop that one. And I'm very agree with Prof. Chu. If we are afraid happen the bleeding, just left the guide wire there. So if we need, we can come again anytime with the easy track it's already made before. Thank you, Prof. Chu.
Yeah, I agree because there is still controversial about the role of percutaneous nephrostomy for bleeding control. And basically, I place the nephrostomy tube when I worry about the ureter obstruction with clots. So the urine drain is important to lessen the bleeding as well. So that's why I placed the nephrostomy tube for the risk of ureter obstruction. And I think I got this idea when I do HOLAP, basically BPH surgery, HOLAP and bipolar, because when I can see the bleeding while irrigation, that would be arterial bleeding, and when I stop the irrigation, I can see venous bleeding. So just according to the irrigation status, maybe we can roughly differentiate arterial bleeding from venous bleeding.
Okay. Yeah, so thank you, Prof. Choi and Dr. Nur. So maybe Dr. Poncho, do you have any maybe different explanations?
Yeah, if the bleeding, I already agree with Professor and Dr. Nur Rashid. I only want to add if for the beginners who will doing the PCNL, monitoring of the blood pressure is very important. If we have the patient, the blood pressure is lower in certain time, one time is enough. We have to stop the operation. Because if we have the blood pressure is lower, lowering, it means that the bleed is a little bit too much. We have to stop the operation. Don't wait until the second or the third blood pressure drop if want to we do the safety of the patient.
Okay, so yeah, I think the hemodynamic is always we have to precaution to
Yeah.
that. So another question from Dr. Fikri. From the lecture of the Professor Cho before, you said that you give the ferrium or injection
Yes.
preoperative for the Stackhorn stone. So can you explain us about it again? Maybe do you always do that kind of procedure for every PCNL or not?
No, basically, if the hemoglobin level is low preoperatively, so if we inject ferrous component 3 weeks prior to surgery, the hemoglobin level will be elevated 2 to 3, so transiently. So maybe for patients with a mild degree anemia, then I can use this.
How about the dosage? Do you have maybe a recommendation of dosage?
Just one ample, but just the dosage is a little confusing. So maybe I can check it soon.
Okay,
Sorry,
okay. Yeah. Yeah,
just one
because
ample.
yeah, we usually don't do the injection like that like you do. So I think maybe it can broaden up our knowledge.
Basically, I never see any urologist who is using the pharyngeal ferrous component.
Yes. Okay, so another question from Dr. Octoferial Aslim, Dr. Yayan. Yeah,
Mhm.
he's so active, I think, in Facebook. So for the Dr. Nurashid about the exit plan, in order put the double G stand with thread, so we could simply take out the double G stand without any instrumentation. Could we routinely do that for both male and female patients? Is there any tips of the procedure?
Usually, I just put the normal double G stand and then cut the string, because usually I'm taking out the double G stand uh, 1 hour later. If not, sorry, one month or 4 weeks after, because after we decided if there is no more residual stone and we don't need any other added treatment, we can take it out with the uh, local anesthesia. For the men, usually we can use a flexible cystoscope. For the lady, we can use a rigid cystoscope. So I think it is simple, because if we just put for the one days, usually I just put the urethral catheter. I don't put the double G stand for drainage from the urethra just for 1 day. Usually, if I put the double G stand, I will take it out the double G stand after 4 weeks or 1 month. Thank you.
Okay, so maybe Prof. Cho, do you have any experience with using the double G stand with strings?
Uh, Basically, I placed WJ catheter for 7 to 10 days. So I removed the retrieval sling basically because after 3 to 4 days, I feel there was an increased risk of urinary tract infection. So just uh, I normally just remove the retrieval sling if I want to place the WJ catheter more than 5 days.
Okay, yeah, because usually in Indonesia we don't usually do use the double G stand with the string, but in our hospital in Ciptaman Kusuma Hospital, now we do the study to analyze the double G stand with string, especially for the female patients after the maybe the simple URS stones surgery, because we can reduce the procedure of the removal double stand. But yeah, so I think we have to analyze maybe the pain after the procedure when the patient do the removal of the double G stent alone in the home. So yeah,
Yeah.
I think yeah.
If we want to study that, the most important part is the narrowest part. That means uretrovesical junction. So
Oh,
if we can make some hydronephrosis, of course the whole ureter can be intact, but basically the junction can be problematic. So you have to find, or you have to include some parameters for measuring the status of uretrovesical junction. So maybe if yeah, you can get some acceptable, feasible results for that study. Just and give the manuscript to me. Just I review it.
okay. Thank you, Prof. Cho. But I interested that you mentioned the ureter vesical junction measurement. Do you have any uh, what kind of measurement that you can do to analyze the ureter?
Basically, if you do the ureteroscopic procedure in the distal ureter or mid ureter, upper ureter, then you can put in the ureteroscopy, right? But it can delay
Yes.
the uretrovascular junction. It can make some traumatic procedures at that point. So the healing process we don't know at all. So just if it makes some stricture at that level, it can be some the problematic. Basically, the distal ureter has a reinforced muscular layer compared to the mid ureter or upper ureter, right? So of course we don't just we don't need to worry about some laceration to the out surface of the ureter, but basically the healing process can make some stricture, uh, yeah, of course, even in distal ureter as well.
Okay,
But
thank
I
you.
mean the narrowest point is uretrovesical junction. So when you retrieve the scope, you need to check any laceration or traumatic portion of the vesicle junction level.
Okay, thank you, Prof. Cho. So maybe Dr. Poncho, can you give us maybe experience with the double G strand with the strings?
Double G with the string.
Yes.
Uh,
I mean, maybe so we don't need to do the removal of double G stand with the cystoscopy.
no, I don't have any experience on it. Usually, I do the conventional removal of the G-stent using the cystoscope.
Okay, so yeah, I think maybe we can wait for the result of the our in our hospital study.
Mm.
So we move to the another question. So this is also a question from the Dr. Ortopera Aslim. So for question for Prof. Cho. So he just curious in nowadays. Do you routinely do the multi-track supine PCNL, or do you always do the endoscopic internal surgery combined?
Basically, 30% and 30%. So 30% multi-track, 30% flexible URS, and the single track for the rest of the cases. But this is a roughly calculated case, and actually I don't have the exact number of cases for using flexible URS and multiple track. But it depends on the anatomy, and basically the upper pole puncture for prone PCNL and the lower pole puncture in supine PCNL are the concept are almost similar because the close the shortest length from skin to kidney. So and we can make the most straightforward the direction from lower pole to the upper pole calyx, but when there is some multiple stones or larger stones in the mid-pole calyx, then I think the flexible ureteroscopic approach can be good. Another puncture can be good, but I already told you that there is some big spleen or liver or some other anatomical abnormalities. Then I worry about the organ injury. So in this situation, I prefer to use flexible URS to another percutaneous tract. But case by case, I'll calculate my own cases.
So how about the endoscopic guided PCNL? You know that many urologists from USA use the prone, I mean the split leg prone position, and then they do the PCNL with the prone, but the leg is split, and then they do the combine, and then they puncture the kidney with guided with the flexible URS. So how about it?
Sure, you can consider the endoscopic guided puncture. That means, but some different meanings because there is a device, needle puncture device from flexible URS to the skin, and of course and another meaning is under endoscopic view or guidance. You can make a needle puncture routinely, right? But you can see whether there is the needle tip is located just inside the papilla or not. So,
Yes.
but of course, if you have experienced urologist for second surgeon and who can handle the flexible URS easily, then maybe the direct accurate puncture can be available under endoscopic view or guidance. But just you need to worry about the flexible URS damage while you need and while you advance the needle puncture needles. So just yeah, it can be very expensive procedures for all of us.
Agree.
Okay. Yeah. So yeah. So back to the supine PCNL, maybe I want to ask to Dr. Poncho, do you have any tips and trick? You know that maybe in Indonesia, we don't usually use the dilator with the balloon. Yeah, with the balloon. I don't know in Korea. Maybe Prof Cho usually use the dilator with the balloon, and then if you do the supine PCNL with the ultrasonography with the balloon, maybe it is more easily. So maybe Dr. Poncho, can you share us about if you use the metal dilator or maybe like the Alkan dilator? Do you have any tips and tricks for that?
Yeah, thank you, Dr. Widi. If you want to do the X-ray free PCNL in supine position using Alkan telescopic metal dilator, then I have a trick that we have to do. I have to make sure that the tip of the first metal dilator is always inside of the pelvic system. How can we know in under guiding of the ultrasound? There is one trick that we have to make make irrigation of water from the ureter using the ureter catheter inside of the system pelvic, and then we can, if the water come out from the metal dilator, for sure that the metal dilator is inside of the pelvic calyces, not inside or before in the parenchyma or the overshoot going out of the kidney. So we can make dilatation carefully from the small one until the largest one, and make sure that the water always come out from the metal dilator. If the waters always come out from the metal dilator, it means that the distal part of the tip of the metal dilator is inside of the system pelvic system. Of course, this technique you need to do the metal dilator first, more than 100 safely. So make sure that the metal dilator is not hypermobile, so it can be static inside of the one point of the intrapelvic system. That's Dr. Vidi.
Yes, maybe Prof. Cho, can you give us your experience? Do you
Yes.
ever do the supine PCNL with the ultrasonography totally X-ray free?
No, just I combine in almost all cases. And when I place the needle, just when I do the needle advancement, I use ultrasonography. And if the needle tip is located inside the kidney and especially callus, then I use a fluoroscopy for inserting guide wire into the urethra, or just I call this ribbon technique. That means that when I do the local puncture and I insert the guide wire into the apopocallis and it goes around in the apopocallis into the urethra. So at that time, without fluoroscopy, I cannot do this. So I think if the guide wire is just going through the urethra, it is absolutely helpful for inserting and making the percutaneous tract. So I try to make it anyway. And for balloon dilatation, basically, it is very helpful if the puncture tract is not, it doesn't have such a straightforward direction. So when I do the metal dilator, it's just we can see some jackknife guide wire. So it is very difficult to make the straightforward the puncture. So yes, if the track is curved, then I prefer balloon dilatation to metal dilatation.
Okay. So I think the time is now at on 9 p.m. So from the speakers, do you have any questions? Maybe Dr. Poncho want to ask to Prof. Cho, or Dr. Nur want to ask to Dr. Poncho? No?
Oh, I think I don't have question. It's already 11 o'clock for Professor Cho.
Yeah.
Almost in the middle of night.
I forget that tomorrow is Sunday, but I talked to you that tomorrow is Monday. Okay, so I think, and that brings us to the end. So once again, we thank you to Prof. Cho, Dr. Nur Rashid, and also Dr. Poncho, who gave us so much knowledge. And I think the discussion is very fruitful, and we hope that it will broaden up our insights, especially on the kidney stone management, and maybe try to apply that to our patients. So last but not least, please stay safe during this pandemic. So thank you. Assalamualaikum warahmatullahi wabarakatuh. And I will give back to Dr. Hosia as MC.
Kamsahamnida.
감사합니다.
Thank you. Kamsahamnida.
We love Korean drama. Okay, thank you.
Thank you very much, Professor Sung Yong Cho, Dr. Nur Rashid, and also Dr. Poncho Wirowo for the very comprehensive and insightful topics, and also Dr. Widi Atmoko for moderating the very active discussion and the very active question and answering discussion session. And now we are coming to the end of tonight's event. On behalf of the committee, I would like to once again thank to PT Advanced Medica Corpora Carl Stores as the sponsor of this event. And again to Prof. Cho, Dr. Nur, Dr. Poncho, and Dr. Widi as our esteemed speakers and moderator, and everybody who is involved, and also, of course, all the participants of tonight's event. And I would like to remind all participants that all recordings of this event will be available on demand on YouTube channel Urologi FKUI RSCM. And also, after this session is over, there will be a barcode that you can scan to give any feedback to our committee. And we look forward to see you all again on next episode of JUMP 2020 on September 17 in the morning in our live surgery episode presenting robotic and freehand prostate biopsy with Prof. Khaidir Arif Mokhtar and Dr. Agus Rizal Hamid. Okay, that's all for tonight. I'm Jose. Thank you, good night, and wassalamualaikum warahmatullahi wabarakatuh.